Hi everyone, I want to talk to you about ectopic pregnancy. The woman is bleeding, she's having pain after she has missed a period. Okay, let's go. An ectopic pregnancy is that pregnancy that is not in the uterus. The ultrasound will reveal that there is a gestational sac, but not in the uterus. Also, the woman coronary gonadotropin serial measurement will reveal inconsistent rise, as may be expected in a viable pregnancy. In other words, the woman coronary gonadotropin level that is expected to be rising consistently will rise, but not as it should be in a normal pregnancy. But the missed period is true. The woman would have missed her period for almost 6 weeks and sometimes even beyond before having any symptoms at all. And also, the pregnancy symptoms are true. In fact, she's not faking anything. The only issue here is that the pregnancy is not within the uterus, it's not inside the uterus. So it's elsewhere. We will soon know where the pregnancy could be. And when you measure the human chronic gonadotropin level serially, you are not going to find what you are expected to find in a viable pregnancy. So that would be a clue that this pregnancy is not viable. This pregnancy is not likely going to go to term. This pregnancy is not growing well. Okay, the story will start by the doctor congratulating the woman, and the woman might jokingly say, congratulating me on what? Um, the answer will be a pregnancy. Okay, how did you know that you're pregnant? Yeah, most of the women would have had their own pregnancy test, or some will not be sure whether they're pregnant or not. The issue is just the missed period. Or the doctor told me that my symptoms are the symptoms of a pregnant woman. The story could go in many different ways, but one thing is constant. The period is missed, the signs of pregnancy are there, and the woman is now here because she's bleeding. The history from the doctor will include when was the last menstrual period, because with that, if it is known, we could estimate how old the pregnancy is today. And it will also include whether the woman has been having regular menses before. If not a regular pattern before, then ultrasound might be needed to estimate the gestational age today. He or she could go back to the age of menarche and how often the woman menstruates. And if she's menstruating regularly, for how long? Any bleeding in between menses, number of menstrual pads used. That will help to quantify the amount of blood loss. Yes, as per the risk factors, it's possible this woman would have had pelvic inflammatory disease. And if that is the case, that could have led to secretions that would have blocked the passage. And when that blockage is in existence, it's either there will be infertility because there won't be fertilization, or if there is fertilization at all, by the time the product, the zygote, is expected to move down and be implanted within the uterus. There's time period to do that. But when there is blockage along the pathway and the zygote couldn't move, freely into the uterus, implantation is bound to occur anywhere the zygote will be. By the time the implantation is expected to be formed, it will just be formed there. And it's possible this woman would have had ectopic pregnancy before, so it could reoccur. Past gynecological surgery, particularly tubal surgery, could give a clue that addition has caused this obstruction of zygotes being implanted inside the uterus today. Intrauterine device usage in the past or currently could be responsible for this. Combined oral contraceptives are not exonerated as well. And the history of gonorrhea or chlamydia infection in this woman before will give a clue as well. Past abdominal surgery or past pelvic surgery will give a clue to any possible addition that we might be dealing with that could have resulted into this. Smoking, or this woman had implanted product of in vitro fertilization right now, all should be asked from this woman right now. We're still on the risk factors. Majority will have no risk factors at all, or the only issue is that they're currently on IUD or on combined oral contraceptives. It would be good to delve into the past DNC. You understand what I'm talking about, and of course, the interaction with partner and the safe practices that would have prevented infection, number of partners discharged, and infections that occur and associated pain. We're just going to go over the entire history that could be very helpful at arriving at the diagnosis. Still on the history, we want to know how many times this woman had pregnancies before. How many of them were up to term, and how many were delivered prematurely? Any abortion, spontaneous or induced before, and the number of living offspring. And as per this bleeding, you want to ask, when did it start? Is it bright red? Any clots? Did you notice any tissue found? Because that will give a clue whether it is something else. It's not ectopic pregnancy, or you don't even have any reason to worry here, because it could be incomplete abortion. And you're going to quantify the amount of blood by the number of soap pads used. And you want to know the effect of this bleeding on this woman by asking if the heart is raising right now, and that is tachycardia. Is she feeling dizzy because the level of blood is shutting down? Any pain in the abdomen? Any pain relating to shoulder? Yeah, pain relating to shoulder is very common in ectopic pregnancy. As a matter of fact, that is the clue that some doctors will get, and before doing any test or anything, they'll be working on ectopic pregnancy right away. decrease in urine production if there is decreased volume of blood, and the tummy is bigger than expected, sometimes not because of ectopic pregnancy, but because of molar pregnancy. Because now that the woman is bleeding, uh, it might not be as a result of ectopic pregnancy alone. So you want to take history that will give a clue that it's not ectopic. So if the tummy is unexpectedly bigger than expected, given the gestational age of the pregnancy, then you might be concerned about molar pregnancy. So the history of bleeding will continue by asking the woman if she's been diagnosed with any bleeding disorder. Because if she has been diagnosed with any bleeding disorder, then what you are handling now may not even be ectopic. And even if it is ectopic, that is an indication that it's likely going to be worse because, for example, somebody with von Willebrand disease is now bleeding, and you know securing in most cases will have to be very urgent and meticulously for that matter. Liver problem because liver is responsible for synthesizing vitamin K dependent clotting factors and very, very vital too hemostasis in general. And you need to find out if this woman is on anticoagulants or antiplatelets because that would determine whether you're going to stop the medication right now and another pathway to go. Particularly, you might be looking for the antidote to that particular medication right away. Father's rhesus factor, in the sense that if the woman is rhesus negative and the father to the expected baby is rhesus positive, uh, you might have to get your Rugen at hand today because in any procedure involving the fetus and the mother, in a rhesus negative mother, will warrant Rugen administration. You know the woman's rhesus because that's why I said you know the woman's rhesus status. If she's negative and the father is positive, then you have to do something right now. Father's blood group, and whether O positive, AB positive or negative, and of course the blood group of the mother should be known. Where could you find the ectopic pregnancies? Could be inside the ovary, could be in the abdomen, could be in the interstitial part, cervical part of the uterus, and intramural, in other words, within the thick uterine wall, within the myometrium. To see that the uterus itself, inside the uterus itself, is out of this list. What are the possible differential diagnoses here? This might not be ectopic pregnancy, it could be threatened abortion. I will talk more on all this later on because in threatened abortion, there's no abortion yet. The pregnancy is viable. The fetus is doing okay, but there is bleeding. And when the woman is examined, the cervix will still be closed. And the ultrasound will show that this is a viable pregnancy. So you do nothing about that. Allow the woman to rest, and the rest will be in order. Inevitable abortion, just like the English word inevitable. This time, the product of conception could be even be seen because the cervix will be opened, there will be pain, and blood will be, more than a threatened abortion. In complete abortion, the entire product of conception is out, but the woman is still bleeding. Trauma to the cervical area or vaginal area that is now showing on the part of the woman as spotting or bleeding could be there, and this could be as a result of abuse. The woman has been spanked by the husband, kicked in the tummy, and so on and so forth. If it is early part of the pregnancy, like I've mentioned previously, could be implantation bleed, in the sense that when the placenta is being implanted, there could be shedding of some of the blood vessels, but it's not going to be massive. But then you need to rule that out. And I've mentioned possibility of molar pregnancy the other time, where the uterus will be excessively bigger than expected. So these are possible situations that could present close to how ectopic pregnancy will present. What are we going to do? It could be diagnosed clinically by taking history and physical examination. Ultrasonography will reveal that there is pregnancy, but it's not within the sac. If you take serial beta-woman clonic gonadotropin, it will not rise as expected within 48 to 72 hours. You do complete blood count to know how far this has affected the volume of blood in this woman, but then immediate complete blood count in a woman that is bleeding right now might not give the true picture. Anemia is not going to be reflective when the blood loss is acute. Then you do liver function test, because I told you majority of the clotting factors are produced within the liver. Then you want to know what is happening to the kidney. Is the kidney shutting down? Because when the volume of blood is down, then filtration is also down, and we might be dealing with oliguria or acute renal failure. Blood group and cross-match, because you may need transfusion here in the next few minutes. Determine the rhesus factor of the mother and the father, because you might need Rogan to prevent trouble in the next pregnancies. What are the possible outcomes here? It could rupture and lead to death. Could be aborted through femoral into abdomen or ovary, and it could resolve spontaneously. So it is not all ectopic pregnancies that will end the same way. But when it ruptures, it could lead to death because there will be massive bleeding. And it could be taken care of by nature on its own, aborted through the fembri or the fallopian tube, and implanted in the abdomen or ovary. And it may resolve spontaneously on its own. The treatment here will be surgery mostly, but could be medically treated. All we need to do is stabilize the patient with IV fluid and blood if needed. Remember Rogan if this woman is rhesus negative. And the management could even be expectant management, watching and waiting, just stabilizing the woman, but that decision will be made by the gynecologist. The prognosis here could be there may be no death if promptly treated, and ectopic pregnancy can reoccur, can be pregnant with only one tube. Yes, it's only that the chances will reduce in half. When you have two tubes and you have a probability of 100% being pregnant, now that you have one tube, it goes without saying that that probability will drop. So in conclusion, not all pregnancies are normal as per the location of that pregnancy. So my advice is to act quickly to save your life. You can die from massive bleeding. So what you don't know, but you know one thing, that you missed your period and now you are bleeding, now you're having pain. Quickly seek urgent attention. I'll be making more presentations on other causes of bleeding in pregnancy and even all causes of pain in pregnancy. So kindly be on the lookout. So thanks for watching my presentation. Kindly subscribe to my channel so that you can get these presentations immediately they are published. Thank you. And my desire is that less people will be dying from treatable causes. Thank you.